Hello, everybody. Hello, everybody. Good afternoon. It's at the top of the hour, and it's my pleasure to meet everybody here today. Thank you for everyone who is tuning into today's presentation. Let me make sure that, can everyone see my screen? Okay, it's now in presentation mode. My name is Nkechi Ogbo, and I have the honor and privilege to sort of like start off this webinar. It's the TSU Baylor College of Medicine P20 CURED webinar, and this is the second of its kind, with the first taking place last month. And today's is under the title Community Engagement and Cancer Health Disparity. Thank you all for making it here today also. And on behalf of the director and principal investigators, Dr. Veronica Ajewole Muema from the TSU side and Dr. Rain Rouse from the Baylor College of Medicine, we want to appreciate you all for taking our time. Thank you. So there will be a Q&A session at the tail end of this presentation. So please feel free to post question and answers our online attendees, and we'll try to get to those. Now I'm going to bring up the moderator for this webinar, and it is Dr. Flora Estes. Dr. Flora Estes is an associate professor of pharmacy practice for Texas A&M University College of Pharmacy and Health Sciences, and clinical faculty pharmacist specialist, drug information at Avenue 360 Health and Wellness. Dr. Estes has over 20 years in academic pharmacy with clinical research in the area of health disparities with a focus on genetic renal disease, specifically polycystic kidney disease. She also serves as PI for the Texas A&M University Research and Innovation Awards, exploring the genetic component of chronic kidney disease. Community Council of Greater Dallas and Texas A&M University's College of Pharmacy and Health Sciences All of Us Research Program, Student Researcher Initiative Phase 1 and Phase 2. Now here, this initiative pretty much discusses medical mistrust and vaccine hesitancy in the minority community, especially among African Americans, past and the present, and now in the era of COVID, as well as she's the co-investigator on numerous projects. Dr. Estes is also a faculty research mentor in various universities' summer undergraduate research program, including the TSU LEAP program. Dr. Estes is the TSU co-lead of the Collaborative Cancer Research Education Program within this P20 CURED program. And Dr. Estes is actively involved in national organizations such as American Association of Colleges of Pharmacy, Special Interest Group, American Pharmacists Association Immunization Delivery, American Heart Association Hands-Only CPR Program, the All of Us Research Program, faculty advisor for Phi Lambda Sigma Pharmacy Leadership Society. She serves on the TSU Faculty Senate and advisory board member for Houston Community College Coleman College Pharmacy Technician Program and board pharmacy for the TSU COPHS Alumni Chapter. Thank you so much, Dr. Estes. Over to you.
Thank you, Dr. Huckbo. I appreciate it, and welcome everyone for attending today's lunch and learn, if you will. Just to kind of share with you about our program, this is sponsored by the National Institute of Health and the National Cancer Institute Center to Reduce Cancer Health Disparities. This is a grant that we were awarded $1.1 million over a 5-year period. And what's notable about this is it's the only grant that was funded in the United States in this cycle. So this is very commendable. The program, again, is entitled P20 Partnership Collaborative Union for Cancer Research, Education, and Disparities. And that's where we get our acronym CURED. So through this award, we will develop a collaborative alliance between Baylor College of Medicine and Texas Southern University for cancer research, education, and community outreach, which we are doing today. It also includes training and promoting a diverse biomedical research workforce and supporting a pipeline of collaborative, innovative cancer research pilot projects. So we are training our current and our future generations of students as researchers in cancer and other health care disparities. Next slide, please. Can you advance next slide? Thank you. So this is our team. So we, as we said, this is a collaboration between Texas Southern University and Baylor College of Medicine. And on the TSU side, we are being led by Dr. Veronica Ajawole, who is our primary investigator. And on the Baylor College of Medicine side, we have Dr. Rain Rouse, who is the primary investigator for the BMC side. And as you see, the different team members that's associated with this project. Next slide. So again, welcome to our October webinar. As you see the link, please note the link above can be used for this and other webinars and events and activities that we have planned. Just a reminder, make sure that you complete the survey. A link will be posted in the chat. And we also want to remind our community health workers who is getting able to obtain CE credit for this event to make sure that you sign in and that you also complete the program evaluation. Next step. So I want to introduce our speaker for today, Ms. Rosalia Guerrero, who has worked with the community health workers and other public health frontline workers for over 20 years throughout the state of Texas, including urban, rural, and border communities. She currently serves as Director of Vulnerable Populations for the Texas Epidemic Public Health Institute at the UT Health School of Public Health and serves as an adjunct faculty at Texas Southern University and the College of Pharmacy and Health Sciences. Welcome, Ms. Guerrero, as our speaker for today.
Thank you, Dr. Estes, and thank you for inviting me to this great event. Today, we'll be talking about community engagement and cancer health disparity. I'm going to start by just giving a few slides of overview. In order to move forward, we have a great panel today and hope we get some good conversation going. So we're just going to get it started with just some background information, starting with today we'll be talking about cancer health disparities. So cancer health disparities are differences in cancer measures. This can be either in new cases, in existing groups of people that have cancer, death and health complications that come from a cancer diagnosis, who survives longer, survivorship, the financial burden to different people around cancer, screening rates among different populations, and at which stage of diagnosis at what stage people get diagnosed. And what's important here is that these differences are preventable and these differences are seen between different populations. So we need to keep that in mind. So in the next slide, we'll talk about who these cancer disparities affect. And what factors contribute to cancer disparities? Why do these things happen? And who do they happen to? We start with race and ethnicity. This is what we're most, this usually comes up in the news or in conversations that some groups have more disparities, incidence, prevalence, at what stage, screening rates, right, among different ethnic minorities. So, and we're going to go a little deeper into some of these. People who lack insurance, not having access to health care is definitely going to impact outcomes when it comes to cancer. People with disabilities, who their outcomes and their screening rates are much lower than the general population. People who are incarcerated, older adults, individuals that live at a lower socioeconomic status, who have less income or have a lower educational attainment. So folks with a college degree or who have even applied to college might have better outcomes than someone who did not finish high school. Same thing with income. Individuals belonging to a sexual gender minority community and LGBTQ plus community, they have, unfortunately, they can have worse outcomes than the general population, just like older adults, adolescents, and young adults. People, immigrants, refugees, I'll even throw in there folks that English is not their primary language, and Native Americans. And even within our own community here in Houston, Harris County, there are certain zip codes, places where you live, certain neighborhoods that may not have the same resources. There are cancer health disparities among those geographic regions or zip codes. If you want to go to the next one, next slide. Now, it's not, if we understand the importance of understanding disparities, can lead to change. This is the reason we really take a look at the numbers, who's being screened, where are they being screened, taking a close look at the individual factors. And by looking at these factors and working as a community towards not only understanding, but doing something about it, we can bring down these disparities. And we have seen progress over the last years. If you'll notice, specifically looking at lung cancer between non-Hispanic Black men and non-Hispanic white men, you'll see the disparity in 2000, and just in 20 years, they're almost the same, right? Not where we want it to be, but we're making progress a lot closer. And of course, we'd like that cancer rate to come down overall. Now let's look at cancer death rates. We've seen between just general white and Black populations since 1990, you'll notice that the cancer death rate was 33% at that disparity, and now we're down to 11%. But again, we're making progress, but we still have a ways to go. And this information, you can look, if you read more deeply about the very specific populations and get more examples of where we've made progress and where we need to go. This comes from the American Association of Cancer Research. This data comes from the Cancer Disparities Progress Report 2024. So this literally just came out a couple of weeks ago. So a lot of good information. At the end of the presentation, I do have the link. So it's if you are working in this area, if you're working in the community and are promoting healthcare, it's good to have some of this information with you. So there is good news, all right? So, but still, we have a way to go. It's still considered a very important public health challenge. Uh, that's why we're here. That's why we strive to have these discussions because we still have progress. Progress still needs to be made. We saw in the last slide that the disparity has come down. The overall cancer death rate has come down for all populations, and the disparity has narrowed, but still, Black people have the highest overall cancer death rate among all ethnic groups. And some of this has to do with cancer screening, right? So it depends on who gets screened. That can lead to, and then of course that's impacted by your insurance or availability of medical resources. If you live in a medically underserved area, well, that's going to impact how often you get screened and your access to any kind of treatment. There is incidence and mortality rate for stomach and liver cancers are significantly higher in Asian populations and in Hispanic populations. So we not only look at cancer disparities in general, but but we also want to look at specific cancers so we can come down to the to figure out who we need to address ourselves to and under which specific cancer. So the more we know, the more specific we can get, the better. So here, stomach cancer and liver cancer significantly higher in Asian and Hispanic populations. Native American women are 21% more likely to die from breast cancer compared to white women. Rural counties, where we talked about geography, residents of rural counties are 38% more likely to be diagnosed with and die from lung cancer compared to those living in urban areas. And compared to cisgender men, transgender women, or men who have transed over into women appear to be at a 60% lower risk of developing prostate cancer, right? Which makes sense, but they're nearly double the likelihood of dying from it. Again, so the disparities can be either in screening, it can be disparities in treatment, in incidence, and in survivability. So we look at that, right? So we look at, we just don't throw a blanket over everybody. It's important to understand the different disparities among the different populations. And as we said, these disparities cause disparities in behavior. And when we talk about behavior, we talk about, are we going to our regular screenings? Are we getting our physicals? Are we following up? So are we able to follow some of the treatment plans? So cancer screening, we see only 64% of eligible Asian populations were up to date with their cervical cancer screening, right? Compared to 78% of white individuals. Women under the age of 65 without any insurance were 50% less likely to be up to date with breast cancer screening. So we see insurance has an impact. And of course, insurance can be attached to work, it can be attached to your socioeconomic status. People may be working, but maybe they have part-time positions or working in industries that don't provide insurance because they might be in a lower paid type of work. So you have to take all these into consideration. Cancer treatment. there are, of all the new approvals under FDA, if you look at any kind of promotion, like either in the news or on TV, you'll notice that there are new therapeutics that come out like every day for cancer. There are new clinical trials. 90% lacked adequate representation of Black patients. These are people that are going into clinical trials. It's important. Clinical trials are important because that way we know if they work on all of us, right? So if we don't have representation from certain ethnic populations, then we'll just have to rely on the outcome of some of these trials, right? And then we become part of that trial when we start using those treatments and figuring out if they are impactful for us, if they work for us. And compared to non-Hispanic white women, non-Hispanic Black women with breast cancer are less likely to receive curative surgery. So we really need to take a deep look at some of these and go by the data. So, this is just factual, and we need to understand why these disparities happen. And that's why we have a panel. We're gonna discuss that, because we need to come up with solutions together. Okay, the next slide. So just as a if we look at this as a continuum and why these disparities actually are perpetuated over time, we really need to look back at history, right? Looking at the institutional racism that has existed, discrimination, the segregation of different types of health care where the larger cancer institutions exist, where the healthcare exists, and who has access to them. So this leads to these structural inequities of who has insurance, right? But when you go into a hospital to clinic, the first thing they ask is not your name, but do you have insurance, right? And just different injustices that not only affect healthcare, but everything in our lives. It's important to look at our social determinants of health that affect all of us in our behaviors, in our health. This comes, and we mentioned them, education, our zip code, where we live, our level of education, where we work, what our family looks like. All these affect how we move through the world every day, our environment. We're a part of our environment, and we're also impacted and molded by our environment. Then this can lead, if you add in the historical discrimination, social injustices and structural inequities that exist, along with the social determinants of health, this is going to create disparities in every level of cancer care, from the development of new drugs to reducing people's risk, because some risk can come from the environment, like who lives close to like an industrial fence line, or who lives near the railroad tracks in Fifth Ward. This creates risk in the environment. So this risk reduction, early detection, we talked about screening, who gets screened, who waits too long. Treatment, we saw the data on certain women would get therapeutic surgery before others. And then survivorship, of course, all this, the development of drugs, risk reduction, how people are screened and treated will have an impact on survivorship. it not only does this create disparities in how people are cared for, but also we have disparities in actually the workforce, right? Who goes into the medical field, who goes into the research field, right? Our physicians, our physician scientists, those that are doing the work of trying to find new drugs for our community. Are they from our community? Do they represent our community? Usually, unfortunately, the answer is no, and other healthcare professionals. And all of this leads to, of course, adverse health outcomes. Where there's disparity, you're going to have a worse outcome than someone that has the privilege of having being in a better environment and not having to carry the burden of some of these inequities. Okay, go to the next slide. So this leads us to community engagement. So what do we do about these inequities? What do we do about disparity? Over the years, we've found through research, through community, talking and working with community, we have found that community engagement can be very impactful in addressing some of these disparities. And as a definition, community engagement involves actively partnering with communities affected by cancer disparities or any disparity in all stages of research from the very beginning: intervention development, implementation of programs, and evaluation. It recognizes that community members possess valuable knowledge, experiences, and perspectives that can guide efforts to address disparities. In the case of community engagement, individuals, regardless of their background, are not victims. They are a part of the solution. When you engage in this kind of activity, bringing in communities, you're also going to foster trust with the institution, break down some of those inequities, promote health literacy, build capacity within the community, and that will later enhance acceptability of some of these interventions, right? If you're a part of the solution, then you're going to become active in these programs that you took a hand in creating. And it will also facilitate the identification of community-specific barrier strengths and resources. Every community, every zip code is different, right? Is different. So we can't throw a blanket on everybody. And this will lead to more equitable and, quite frankly, more effective programs that will reduce these cancer disparities. Okay, next slide. These are some of the core principles of community engagement. You can imagine building trust, being inclusive, culturally centered. It's not a fly-by-night thing. It takes a while. It takes effort. It's always ongoing. It's where community is an equal partner, where programs are not promoted, they are co-created with the community. And it takes into account everyone's knowledge, so it doesn't put a high, it's not about who has the most education, but about bringing everyone's knowledge together to form a better outcome. Okay, go to the next one. So these are some approaches when you use community engagement. These are certain approaches that have we know to be effective in reducing disparities in cancer. Building that community trust, building partnerships within communities, developing tailored interventions that are grounded in the community's culture and are linguistically relevant. They speak the language of the community. Improving access to and coverage of health insurance, like Medicaid, Medicare. We still have, unfortunately, Texas and particularly Harris County still lags the rest of the state in onboarding eligible children and adults into Medicaid. These are health insurances that exist, people are eligible for, but are not signed up. Enhancing communication, developing, making sure that providers and patients are speaking, can communicate with each other. Community health workers have been found to be very effective in this role. And then this whole idea of screening, right? Again, speaking to your community. And then we're talking about community health workers. This also leads into patient navigation, helping. We live in a very complex and disjointed medical system that really kind of stacks the chips against people. So when you have a navigation program that helps patients move through the system, open doors for them, it can make a world of difference. As you can see here, the numbers are impacted significantly into participation of any kind of intervention, whether that be screening or treatment or testing, right? So patient navigation, definitely evidence-based. We know what works. It works. Okay, next slide. So kind of wrapping it up, this shows everything that we've discussed in one model. And again, this is in the resources. I like this because it kind of like shows the core principles of building that trust and community engagement and how that can impact. It can expand our knowledge. It can expand the capacity of the community, but also our capacity, our knowledge. It strengthens our partnerships by creating shared power and putting the community members front and center. This can only improve healthcare. It improves our programs. It impacts our policies. And in the end, not only does it reduce disparities, but it actually increases the health of a community, builds not only in healthcare, but also in society, policy. You start to see just a thriving community in all its aspects. So community engagement really goes above and beyond just reducing disparities. Okay. And I think that's it. Next slide. And that might be our last slide. Yes. So these are our resources. Yeah, again, a lot of people working on these issues. So if you look at some of these progress reports, they're very recent about addressing cancer disparities. And if you go to some of these sites, they have specific case studies. I just don't have time to go through all of them, but very specific case studies, specific programs and ideas that you can use in your work every day. So that's it. I hope I wasn't over time, but look forward to the panel discussion.
Thank you, Ms. Guerrero. This is very insightful, and we do want to continue this with our panel discussion. So I want to introduce, we first have Dr. Hoda Bader. She is a health psychologist and tenured professor in the Department of Medicine in the section of epidemiology and population science at Baylor. She is also the leader of the Cancer Prevention and Population Sciences program at the Dan L. Duncan Comprehensive Cancer Center. Dr. Bader research program focuses on developing and implementing psychosocial interventions that leverage family support to improve patient and caregiver health behaviors and well-being across the cancer control continuum. Her early research sought to refine the methods and models used to study dyadic processes in cancer. Over the years, she's expanded that focus to elucidate how individual, interpersonal, and system factors affect patient and caregiver interactions with the healthcare system. She has also employed community-engaged research methods to develop technology-based and multi-level interventions to improve healthcare delivery and outcomes for minority and medically underserved cancer patients and their caregivers. In terms of research productivity, Dr. Bader has 90 peer-reviewed publications and has been continually extramurally funded for over 20 years. Her work has been supported by the National Cancer Institute, the American Cancer Society, the National Institute of Dental and Craniofacial Research, the National Health, Lung, and Blood Institute, the National Institute of Nursing Research, and the U.S. Department of Defense. So we welcome Dr. Bader to our panel. Next, we have Dr. Nkechi Ogbo. She graduated with a Doctor of Pharmacy degree from the University of Minnesota, Duluth, and completed a one-year general practice residency at the Michael E. DeBakey VA Medical Center here in Houston, Texas. She also completed a master's degree in public health with an emphasis on public health leadership from the University of North Texas Health Science Center in Fort Worth, Texas. Over the past 16 years, Dr. Ogbo has worked in the retail pharmacy setting and pediatric hospital setting before joining TSU as the Health Equity and Community Engagement Pharmacist in late February of 2024, where she supports health equity advancement, research, and training initiatives, including the Breast Cancer Screening and Prevention Center. So welcome, Dr. Ogbo.
Thank you.
So this is our panel for our discussion. Please make sure that you're putting your questions in the chat, and we will try to get to those if at all possible. So these are our leaders, with Dr. Ajiwole on the TSU side, Dr. Rouse for Baylor, and then again your speaker and your panel, and I'm Laura Estes, your moderator. So let's get to our first question with Ms. Guerrero. How do you build trust with community that historically have low participation in health screenings? Can you share with us how we can build trust with our communities?
Well, I found it in my experience. Sometimes it's we call certain communities hard to reach, and really it's about we're just not. They're hard to reach because they just don't come out and seek us, right? So it's all about seeking groups, coming out of our comfort zone, and then being, I think the most important, being present, right? And seeking out community before, without the intention of asking anything. Like I was mentioning before, it's not so much the promotion of something, but is reaching out and listening to what the community's concerns are, and start a conversation, right? Without any preconceived notions and without judgment. We all come with our, everyone is different, and we all come from our culture, our knowledge, our upbringing, right? And so it's our job to put some of that aside or share in our humanity and our experiences with others. And that seems to get things going, and just being open, I guess, but really coming in with no preconceived notions or specific asks.
Okay, thank you. So 2, we have to get out of our comfort zones and go to them in order to reach them. Very good. So Dr. Badar, what are some effective strategies that you use to engage underserved communities in cancer prevention and screening efforts? Can you share that with us?
Yeah, absolutely. First of all, I just want to say thank you for having me on this panel. It's really just an honor to be on a panel with so many distinguished speakers and people who have such a commitment to doing work in this area. So in answer to your question, I think, I've used a number of different strategies to engage communities, and just picking up on what Ms. Guerrero said, it's so important when doing research, when trying to develop programs to improve prevention and screening, that we go out into communities and we engage communities in the research process. That includes having listening sessions, trying to understand what are the health issues and concerns that are really pressing and of need in that community at that particular point in time. And that means, as Ms. Guerrero stated, kind of getting rid of the preconceived notions of what I want to do for my research project, and really understanding what does this community need, what do they want, what are the barriers that they're experiencing, and how can we develop programs to really meet those needs. So that involves a process of engaging with different stakeholders, listening to what they have to say, and then not just doing that, but really working with the community to co-develop the programs that we are going to be implementing, so that there's buy-in and so that they're tailored to their concerns. Another strategy that I have really used is, thinking about the issue of addressing barriers. So we can develop a program that might work in one neighborhood, but it might not work in another neighborhood. And because maybe there are, multiple visits involved, or we have different surveys that need to be completed. And, it really, in order to engage communities effectively, I think we have to address some of the logistical barriers to doing research. Things like addressing transportation, providing low cost or free screening services, and as was mentioned also earlier, navigation even to those services so that people can really actively participate. The last thing that I just want to mention also that I have found to be a very important strategy, but one that maybe doesn't get a lot of attention, is really showing commitment to a community. So it's not enough for a researcher or somebody who's interested in doing this kind of work to go into a community because I have a grant and I have a certain amount of time that I need to do my research. And so I pop into the community, I get my data, and then I leave. Right? So that's not good. That actually increases mistrust, because people say, well, the only time you pay attention to us is when you have the grant, but what happens when the grant is finished? So it's really important to create relationships with communities and to keep coming back and to disseminate the research. So if they participated in a project, you need to come back and tell them what happened, what are the results, what's the findings, how did what they did and how they contributed, how did that help advance science? And then that will make people also feel more comfortable about participating in research and really trust you as a researcher. And so those are kind of some of the principles that I've used.
Awesome. That's awesome. And this leads us directly into the next question for Dr. Ugbo. So we're talking about barriers.
Yeah.
So barriers like cultural belief, fear, stigma, how do those prevent participation in cancer screenings?
Thank you so much, Dr. Estes, for that question. And thank you to all our esteemed panelist members and also Ms. Guerrero, who presented on this topic. So when it comes to, I'm just going to try to give an example of something I was part of. So recently, what is it called? In conjunction with UTMB, we hosted like a community engagement session where we just wanted to hear from the community why African-American women were hesitant to go for mammogram screening. And loudly, what we heard loudly amongst the women there was fear. They're being told it hurts, it hurts, it hurts, it hurts. And of course, it's one thing to hear, okay, it hurts, or the fear surrounding it. Then we went ahead and asked, because these are the women, what they are telling us, then what should we do? What can we do to, to alleviate or allay or try to put to rest some of these fears? And they said, just keep talking to us. Just keep talking to us. We'll just keep it. You might think we're not listening, but you just have to keep on coming over and over. Go on with the education. Show us the mannequins, how to do the breast self-exams and whatnot, just keep talking to us was pretty much what a woman had mentioned to us. So I think it's more like, first of all, hearing what the stigmas are, what these fears are. They are not unfounded fears if somebody really believes in it. And then, try to, provide information to counteract those fears, or even bring about maybe people who can also maybe talk about their own experience while they were using the or while they were being performed a mammogram, and hopefully that. And also, like Ms. Guerrero mentioned, providing culturally appropriate materials, like Dr. Badar, I believe, mentioned. You cannot use the same, for example, the same material I used in this community to the same kind of like material to teach them or educate them in mammogram screening to another place that has a very different culture going on. So just making sure that we are tailoring it to the organizations or the communities we're trying to serve. Thank you.
Thank you. So I want to go ahead and take a question, if you don't mind, from our online audience. And one of the questions is asking, what aggressive efforts are being put into place to educate the community, particularly parents and caregivers of children, about the cancer risk that's associated with HPV infection and the potential value of the vaccine, the HPV vaccine, in childhood, especially given a generation of vaccine-resistant younger patients? So, Ms. Guerrero, do you want to start off with that?
Sure, I'd love to. It's interesting, but I think the HPV vaccine is a great example of how we speak before we listen sometimes, and we are still suffering from that. So misinformation happened way before COVID, right? COVID vaccine. And as soon as and it's particularly HPV has been very interesting. And I don't work in a program that has HPV. I'm saying this as a public health observer who saw it unfold real time, where this idea that that came from the community when they heard the information that somehow HPV was tied to adolescent sexual activity. And as soon as those two things were connected, it was hard to work that back from the whole beginning, where it was focused on young girls, when really there were other populations like boys who were just as at risk. And so the information just started eking out. And to a certain degree, instead of making things better, it sometimes added to the miscommunication. So I think there's a lot to learn from how HPV rolled out. But I'd like to say it's really good because we can recover. We have learned to, because no one's perfect, but this building of trust, it took a while. We had to come and because maybe that trust wasn't there at the very beginning, and we laid HPV on top of it. But there's been a lot of concerted efforts from a lot of great programs and leaders that are really going out there and listening to folks and listening to the different specific populations and creating conversations with parents and with young people. So around HPV vaccination, and that conversation is much different from how it started, and our numbers have gotten better. And but we still have a ways to go, just with everything else. But it shows that we can learn from community. So I'd like to hear what others have to say. This is just my observation is seeing how HPV rolled out from the very beginning.
So Dr. Bader, can you comment on this as well?
Yeah, I think I can comment a little bit. My research area is not in the arena of HPV vaccination, but I can tell you that there are a number of concerted efforts. I think one big progress in this arena is, for a while, people were developing very top-down interventions and programs, and we're not even thinking about trying to address different communities' fears and concerns, or even recognizing that those concerns may differ from one community to another. And so now there is a much more concerted approach, I think, in terms of community engagement, to develop more tailored messaging surrounding HPV vaccination. There's also different partnerships occurring between cancer centers, primary care provider offices, and pediatrician offices to sort of provide more education, whether it be written, and different types of partnerships between institutions to help to facilitate uptake of vaccination. And I think, so I think as was mentioned, that, the numbers are improving. I think we do have a long way to go, and it's really just a matter of trying to get to what the pain points are for people, and then trying to break those down and try to figure out what can we do to enhance uptake to make this more clear, because people are afraid. A lot of that is due to misinformation, so you have to correct provide reliable information, but you also have to provide that information in a way that's linguistically appropriate, that's culturally appropriate. The people who are delivering the information, sometimes really it helps for them to look and talk like the people that they're communicating to help to facilitate that trust. And I think now at least there is an acknowledgement of that, and there are efforts to try to make inroads in that regard.
Awesome. Awesome. Thank you so much. Dr. Ogbo, do you want to comment on this quickly?
I think my esteemed colleagues have probably said quite a lot, but the only thing that just came to my mind was maybe the formulation of a community advisory board before such kind of education or such kind of strategies want to be, and get the input of the community they're trying to roll out to. That was it. Thank you.
Thank you. So I think that's about all the time that we have for our Q&A. I want to thank our panelists for your participation and our speaker for today's activity. Thank you so very much for everything that you have shared with us today. So we want to thank everyone again for joining our October webinar. And just as a reminder, to complete the survey, there should be a link in the chat. And also our community health workers, make sure that you've signed in, complete the program evaluation. And you can always click on the link to find out what other great things that we are doing. Next slide. So our next event that's coming up will be Wednesday, November the 20th, for our next seminar or lunch and learn from 12 to 1. So this is right before Thanksgiving. So you still have plenty enough time to sign up and register for this event to attend. Next slide. And we have other activities or events for you to attend as well. In January, beginning in the new year, we have our maternal and child health education and outreach. And we will also have our clinical research and engagement conference in April. So please mark your calendars for these events and plan on attending. I would like to say thanks again. Please make sure that you are sharing this information, not just for yourselves, but for your family, friends, your community centers, your churches, everywhere that you are. Share the information so that we all can be aware and fully educated. Thank you again and have a wonderful afternoon.
Thank you.
Thank you,
having us.
Dr.
Thank
Estes.
you.
Thank you, everyone.
Thank you.
Yeah.
Thank you.